from Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi everybody, welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we continue with the second part of a three-part mini-series regarding both inpatient and outpatient rehabilitation. Today we're focusing on neuro rehab patients and their recovery. For the first part of our discussion today, we're joined by Danielle Schwab, a physical therapist who works with this patient population at the Sarasota Memorial Rehab Pavilion. Danielle, thank you for joining us.
Thank you, Allison.
Can you first address what qualifies a patient specifically for neuro rehab? It's more than just stroke patients who fit that category, right?
Yeah, so when I classify somebody as needing neurologic rehabilitation, it refers to diseases or changes to the nervous system. So changes to our brain, our spinal cord, or peripheral nerves. And so this is people who have had stroke, spinal cord injury, people that have Parkinson's, or maybe even changes to their inner ear system called their vestibular system.
So it's a huge range of patients.
Huge.
There's definitely
Yes.
no one-size-fits-all approach.
Correct.
But what are the biggest challenges that many or most neuro patients face?
One of the biggest challenge is the expectation for the timeline of their recovery. So people will come in and they'll say, okay, I'm supposed to be better yesterday, right? And I'm like, well, changes to your nervous system, it takes quite a bit of time. So people have that expectation, okay, I recovered from my knee replacement and it took 2 to 3 months or maybe even 6 months, but recovering from a neurologic injury can take up to a year. And what we're looking for is promoting something called neuroplasticity, which is the changes to our nervous system. And it's rewiring the circuitry in our system.
So how is a physical therapy plan developed here at SMH? How do you work with this patient population to tailor their needs or to tailor their program to meet their specific needs, since it is that wide array of patients?
Yeah, so the way that it works in the outpatient world is I get a referral from the physician and I do an initial assessment. And in that initial assessment, I am getting their medical history and I do an examination to look at what is their body functioning like right now, what are their impairments, like deficits in strength or balance or sensation, coordination. And then I work with the patient to create a plan that is good for the patient, but then also is supported by our research. And how often do I get to see them? How many visits do I expect? How long do I expect to see them? And so it is a tailored approach, but it's based on evidence as well.
Are there specific protocols that most of them will go through?
The answer is no. I mean, I will have certain patients, certain diagnoses that might fit into a protocol-based treatment framework, but most of the people, it's based on how are they presenting, what are their deficits, and I do a custom treatment intervention approach for them.
In the first part of this mini-series, we spoke with Dr. Ryan Hafner about the Vivastim implant for stroke patients, but not all stroke patients are even candidates for that. So what other technology can be used to aid in neuropatient rehabilitation, whether it's stroke or something else?
Yeah, so here at Sarasota Memorial, we have really a wide range of technologies that we can use. And at the Rehab Pavilion specifically, we have body weight support systems over ground or using a treadmill. We have robotic systems. We have different electric stimulation devices that we can use. We have like gait analysis that we can use. And it's really how can we optimize their intervention and how can we make it faster? And that's what we use all of these technologies for.
Can you talk a little bit about the multidisciplinary team that works with neuro patients specifically in rehab here at SMH?
Yeah, so this is one of my favorite parts about working here and practicing here is that we use a multidisciplinary team approach. And so in the outpatient world, I have physical therapy, of course, but there's different types of physical therapists. So people that specialize more in the neuro, but then also sometimes I need help from my orthopedic colleagues. So maybe I have a stroke patient that also has shoulder impingement. Sometimes I will send them to that physical therapist. And then we have occupational therapy and we have speech therapy. And so we get to meet formally about once a month to help create that plan of care for that patient that really helps them not only while they're in their training, but also preparing for discharge. And then we have informal meetings that happen during our week. And it's really so that I can see, okay, what are they working on in their speech therapy and how can I incorporate that into my session? So if I have someone that needs to take a sip of water in between their exercise, I'm going to make sure that I am using that strategy that the speech therapist has given them to have a safe swallow.
So you just spoke about how much you enjoy working with the multidisciplinary team. How does it impact patient care for those patients that they know there's that line of communication amongst all their providers?
So when we are each a unified team, it really does make the patient feel like they're being heard from all of their providers. And we get to reinforce the concepts that we're teaching them. And so I think it's when someone goes in to see a medical provider, they hear some of what we're saying, but then it takes repetition for that education to really come through and for them to be able to apply it into their recovery process. And so having that repeated information that is all three providers, all three disciplines, and then also our physician teammates that we're referring back to them at times, and we're all saying the same thing, and then the patient finally gets to understand, oh, this is what I need to really optimize my recovery.
Is there anything else you want to add specifically about PT for the neuro patients?
I think that some people think that physical therapy means I have to do bicep curls and I have to do squats. And some people come to me and they say, I don't like exercise. And so I say, well, okay, that's great. What do you like to do? What activities around your house or in the community? And so that's another piece that we do an excellent job here at Sarasota Memorial, is we tailor that intervention to what is their role in the community? What do they love to do? If they want to be able to get onto the floor and play with their grandchildren, well, we've got to practice getting onto the floor and playing with their grandchildren. And so it's taking that intervention, making it something meaningful to that patient, and then their nervous system will change faster and they will improve more in that area.
Thank you so much, Danielle. And that brings us to the next part of this conversation. We're joined now by Debbie Henderson, an occupational therapist who works with neuro rehab patients at Sarasota Memorial. Debbie, thank you so much for joining us.
Oh, thanks for having me. Glad to be here.
For those who don't know, what's the difference between occupational therapy and physical therapy?
So I get that question a lot, and I've been a therapist 33 years, and so I've answered it many, many times in different settings too. And it does vary depending on the type of setting that you're in. Both Danielle, Molly, and I are in outpatient therapy, so our setting is a little different maybe than inpatient rehab or home health and stuff. I talk about function. So both physical and occupational therapy really focus on improving function. However, we look at different areas of function. So I think that's where the big difference is. So with PT, in the neuro population in the outpatient setting, a big area of focus for them is on mobility. So that could be walking, transfers, propelling your wheelchair, rolling in the bed, any type of movement, mobility task is usually under that big umbrella of physical therapy. With occupational therapy, our big area of function is daily activities, which is very broad. So from the time you go to bed at night, and then the time you get up in the morning and throughout the day, or even when you're sleeping, those are daily activities. So if there's impaired function with doing daily tasks, then that's where occupational therapy can step in.
So what are some of the tasks that a patient might come to you and say, this is a really important goal for me, or I've had a brain injury, or I've had a stroke, whatever it is, and this is something I need to get back? What are some of the most common ones?
It really does run the gamut. It could be something like, I cannot tie my shoes, or I cannot cut up meat. My wife has to cut up my steak for me, and I'd really like to get that independence back. Or I would like to be able to do toileting by myself, because, who wants anybody in there when you're going to the bathroom, right? So it really is very patient-oriented and very patient-specific. And when we do evaluations, we really try to tease out what are those tasks that are most important for the patient, and how do we get at those and help them improve.
So why is it important for this specific patient population to have both PT and OT, not just PT or just OT?
Because of the functional areas that we focus on. And then with occupational therapy too, I really focus a lot on, with that neuro population, arm and hand function. We don't like to split up the body, because all of us look at the whole person, the whole body. However, if there's a fine motor coordination deficit, or if there's difficulty moving the arm because of paralysis, they're going to come to occupational therapy versus physical therapy. Physical therapy has their plate full with all the mobility stuff, core strengthening, leg function, all of that, and we only see people for an hour, maybe twice a week. So, we got to kind of divvy up things. But it really is the functional tasks that kind of separate us at times. However, when I do daily activities, there's mobility involved. So I would say occupational therapy is that discipline that tends to overlap a lot of speech and PT, because of that focus on daily activities. Because if I'm going to dress myself, I need to be able to get my clothes out of the closet, so there's mobility tied in there. I need to be able to balance and standing to be able to get my clothes on. So, there's a lot of overlap, but the end goal is usually a different functional task.
So being that there's so much overlap, especially with OT, how important is it to you to have this multidisciplinary team in the rehab pavilion that you can so easily reach out to? You can call Danielle, or in a little bit we're going to speak with Molly. You can walk by them in the hallway and talk about patients, or schedule a meeting to make sure you're all meeting the same goals. How important is that for you?
Extremely important, and you hit on it. It's a team. So it's not only just the physical therapist, the occupational therapist, the speech therapist, it's the doctor, it's the patient, it's the family, it's the caregivers. We all work as a team to optimize function. So if I know PT is walking a certain way or using a certain device, I'm going to do the same thing. I don't want to get the patient confused, for one thing, but I want to be able to have the patient do the same type of mobility in the same way during my sessions that PT has them do. So we collaborate all the time. When you think about walking, and I focus a lot on arm swing and motion there. So if I make a cast for someone whose arm is drawn up, I sometimes will cast them to get the arm down, so when they're walking, we get better arm swing. So I'm going to communicate with a physical therapist about, hey, we've been using this device to keep the arm straight, so when they walk, they get better arm swing, and it helps with their mobility. So we collaborate all the time. It takes a village.
Definitely. Speaking of village, occupational therapy, especially since so much of it is task-based at home, how important is it for you to have sort of the buy-in of the support person or people for that patient?
100% important. I mean, it's the most. In the outpatient setting, we don't get to see people for that long a period of time. My role is to educate and instruct them on, activities, home program, and if they're not doing what I want them to do outside of therapy, we do not make the progress that we could. I'm a firm believer in neuroplasticity and the brain's ability to reprogram itself, but that only occurs if it's intensive, and that intensity has to be done outside of therapy. So I have to do my job of really explaining why we're doing something, why it's important, how to progress. My skill is, once they achieve a certain level of function, how do I progress that skill? Especially with arm and hand recovery, because that is one of the most challenging areas that I address, and it's one of my favorite areas to work on, because arm and hand recovery after a stroke can be very daunting depending on how bad the paralysis is.
So with occupational therapy, even though this is such a wide patient population and what they might be experiencing, what their symptoms may be, how severe the stroke may have been, the traumatic injury, whatever it may be, where they are in their Parkinson's diagnosis, wherever we're talking about. This is such a wide variety of patients. But can you give us sort of an idea of what the process looks like with occupational therapy, where you sit down with the patient at first, evaluate them, and then where you go from there?
Well, I mean, the valuation is so important because of that. You're looking at, you take the medical history, you look at, what was their prior level of function before the neurological diagnosis came along. You look at their home environment, their caregiver assist, how independent they are. You look at their range of motion, you look at their strength, their coordination, their balance, their sensation. There's so many things that we look at in an evaluation. We take all of that information and knowing what the patient wants to work on, and we formulate a plan of care with the patient. That's how you get the buy-in, but that's how to determine where we're going to focus and where they are, where I think I can get them. But I'm a true believer in, I don't like plateaus. I don't believe in plateaus. If all the right ingredients are put in, I will work with someone. I don't care if it's 10 years after stroke, 20 years after stroke. I've been able to help people get gains back. So I never let that stop the process.
What's it like for your team when you all are working with a patient who has had a stroke or had a traumatic accident, whatever it is, when PT, OT, speech come together and you guys get to sit together and see fantastic outcomes, a patient achieve their goals? What's that like for you guys?
It's so exciting. It's very rewarding. And sometimes, I'm involved in, I won't get too much down this road of the Vivastim program, but I had a gentleman that, and that was a very intensive program with stimulation of the vagus nerve. But I got to do like 18 sessions, 90-minute sessions, 3 times a week. And this is a gentleman whose stroke was several years ago, was never able to tie his shoes, and now he was able to use his involved extremity, which was his dominant side, to be able to tie shoes. You celebrate something like that, something that they haven't been able to do for years, and now they had enough hand function that they could actually use both hands and tie their shoes. It's like, yay! We get very excited.
And I'm glad you brought up Vivastim. We did in our last episode, in the last part of this Rehab mini-series, speak with Dr. Hafner about Vivastim. So we definitely encourage people to check that out, especially if you know someone who has had a stroke, because it might be an option. It's not an option, though, for every patient.
It's not, but the concept, though, the Vivastim itself doesn't work if you don't pair it with the intensive therapy. It's all about trying to tap into that neuroplasticity. And so, and that sometimes it means the stars need to be aligned for that to happen. But if those ingredients come together, you do get successes,
And for patients who maybe aren't eligible yet, because I know they're looking to expand who might be eligible for Vivastim, but currently, if you're not eligible, you can still achieve quite a bit.
Yes, ma'am. Amen to that. Yes. Again, there's certain things for the brain to reprogram itself, right? So you need, there's like principles of what makes neuroplasticity occur. And I focus on 4 with my patients. Use it or lose it. Use it and improve it. So we got to progress the function. So everything's got to be tied to that function. And then also high repetition, not 10 to 20 repetitions, thousands of repetitions. And you're not going to get that if you just do what we do in therapy. You got to do it outside of therapy. And then, so the high repetition and the challenge. So there needs to be the right amount of challenge. I usually shoot for about 70%. If someone comes in and it's too challenging, they're going to get frustrated, and they're also maybe going to develop maladaptive patterns that I don't want. So I shoot for it to be challenging enough to tap into neuroplasticity, but successful so they progress. And that's the skill of the therapist, knowing where is that 70% challenge to progress them and have that success.
So it's about about setting and obtaining achievable goals, and then those stretch goals you set later on. Let's get to this first. And then once we achieve that, then we can start talking about
You bet.
beyond.
And we set those expectations during the initial eval, and we reiterate that, and we harp on people about you got to do things outside of therapy. Remember, this is our goal, and and then we do progress notes usually every 10 visits, and that's a good time to look at really going into those outcome measures and say, look, you've improved, or you're not doing what we need to have done. You're not improving. So what do we got to change to make things happen?
Deborah, thank you so much for joining us to add to this conversation. A third key component for neuro rehab patients is speech therapy. That's where our third and final guest today comes in, Molly Daunt. Thank you so much for being with us.
Thank you for having me.
So Molly, do all neuro rehab patients get speech therapy?
So all patients typically do get referred for speech therapy following a neurological event. So whether it's a stroke, a brain injury, Parkinson's disease, ALS, just to name a few, they typically will get referred to us, and then that's when we decide and do an evaluation to see if they would benefit from speech therapy. So most of the time, neurological patients do come to see us for therapy. However, there could be times where maybe their stroke didn't impact their speech or their swallowing. So there could be instances where they don't all get speech therapy. So that's where we come in and do an evaluation and determine if it's necessary or needed based off of their impacts from the injury that they had.
And that's a good point, is speech therapy is more than just speech. So talk about some of the things that speech therapy actually works on.
Right. So with speech therapy, it's a big variety. So if you think of like your neck and above, we work on all of that. So not only is it speaking and communication, but also swallowing. So we help a lot of patients strengthen their swallowing. So after a stroke, brain injury, Parkinson's, they have difficulty with swallowing. So we'll work on different exercises for that. Another big part of speech therapy is thinking skills, so cognition. So that includes memory, attention, problem solving, thought processing. So we'll help a lot with memory skills. And then another thing is language-based tasks. So people who have difficulty with communication, getting their words out, forming sentences, we help them with that word finding and language-based. So it's a big variety of different things in our scope of practice that we get to help people with.
Earlier, it was discussed that neuro rehab really goes across a large variety of patients, from traumatic brain injury to stroke, like you just mentioned. What are some of the unique challenges that this patient population specifically faces that you might not face with other injury when it comes to speech?
So a big part is an adjustment from what happened to them. So let's say it's a patient who just had a stroke. So it's a big adjustment in their life from before the injury to the current troubles or deficits they might be having. So a lot of times it's finding ways that we can help them at home and in their home environment, adjusting to this new life that they are having.
And when it comes to speech therapy specifically, how do you help that patient population set realistic goals and achieve those goals?
So a big part of that is, first, I always like to ask the patient like what their main thing is that they want to work on. So it's very patient-centered, so determining what their overall troubles they're having and what we can do to help them and formulate goals based off of their main deficits. So maybe their goal is to be able to cook again or drive again, or go back to work if they were working before. So we like to center it that way, make it as functional as we can, and find ways that we can implement those goals to help them in the home environment.
So what are some of the ways you might work on speech therapy with this patient population? What are some of the things, because there are so many things, like you mentioned, swallowing, that people don't think of that have been impacted, that impact their day-to-day lives. First of all, we swallow all the time. Second of all, we're eating, drinking, whatever. What are some of the exercises that can help this patient population specifically?
Good question. So there's a big variety of different things that we do. So we do have a program called Speak Out, which is a program that we offer for patients who have Parkinson's, and it helps train them to help their volume and help them project their voice. And it also helps them with their swallowing skills as well. So that's one big program that we do. Another thing is we have communication devices. So people who are having difficulty coming up with words, naming different things, or forming sentences, we have what's called an AAC device, which is essentially an iPad that they could use to help aid in their communication. So that's a big part of it. And then with swallowing, we do a lot of different strengthening exercises depending on what area of their swallowing is impacted. So we typically will have them do what we call a video swallow study first, which is where we look at their swallowing on X-ray to determine if there's any changes with the anatomy. And then we target like that by doing different strengthening exercises.
Because it's all muscles between speech and swallowing. So you're basically retraining these muscles,
Yes,
right?
yes.
Can you talk about how the speech team works with the multidisciplinary team within rehab at SMH to address the total needs of the patient. Like you mentioned, they might have very specific goals for their lives. So how do you all work together within rehab to get them to accomplish those goals?
What's really nice about Neuro outpatient, we do have monthly meetings where we all meet as a team. So speech therapy, physical and occupational therapy, we all get to come together for an hour and talk about patients' goals, progress, and collaborate on what we're doing and mention different things that they could work on with our patients. Also, we get the chance to see each other in passing and talk about how that patient did that day and if there's anything they can incorporate in their sessions. Like, for example, maybe the patient is having a hard time remembering their safety precautions when ambulating with their walker or getting up from a chair. So we can work as speech therapists with helping them come up with memory strategies so that they are able to recall those safety precautions. So it's a lot of just bouncing ideas back and forth, which is great that we have the opportunity to do that and collaborate all together as a therapy team so we can ensure we're meeting the goals that we want for the patients.
Is there anything else you want to add?
I did just want to talk a little bit about the Speak Out program I mentioned a little bit earlier. We have been able to, with outpatient neuro, the past 6 years, we've got a grant for the Speak Out program, which is really great that we have the ability to offer this to our patients who have Parkinson's. So with that program, it allows patients to come and help regain their speech and swallowing skills. And then we also offer a maintenance program with it. It's a group therapy session. So I just wanted to mention that because it's a great program with a lot of good research behind it. And we're very lucky that we're able to help the patients in the community with that program, Speak Out.
So for Parkinson's patients or their family members in the Sarasota community, they just need a referral to Sarasota Rehab?
Yes, exactly. So just a referral from their neurologist, their primary care doctor, just for speech therapy. It could say Speak Out therapy. And they come and we evaluate them, do the program, and then they get to be a part of this maintenance program, group therapy, continuously. So it's a great program that we get to give the patients and offer them.
Molly, thank you so much for joining us. And again, thanking all the guests we spoke with today. Please make sure you join us next time for the final part of this rehab mini-series. We're going to be talking about cardiac rehabilitation and rehab specific to cardiac patients, so be sure to tune in for that. As always, we encourage everyone in our community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.